is chairing the next session. Is currently working as a consultant intensivist at Narayan Multispeciality Hospital, Mysore, affiliation to ISA and ISCCM. His area of interest are critical care ultrasonography, hemodynamic monitoring and antibiotic stewardship. I welcome you to chair the session.
MD Anesthesiology, DM Critical Care Medicine, and PhD and a European Diploma in Intensive Care Medicine. Currently, she is Assistant Professor, Department of Critical Care Medicine, AIIMS, Belur. Consultant in Clear Medi Multispeciality Hospital, Mysuru, India. Her affiliations include Indian Society of Critical Care Medicine, European Society of Intensive Medicine, Indian Society of Anesthesiology and Sepsis Registry. Her achievements: receiver of Prime Minister Fellowship of Anesthesiology for Doctoral Research in 2021, receiver of Scholarship from Foundation of Excellence, an American NGO for MBBS education, and rank holder at university level exams held for MD Anesthesiology in 2014. Welcome to the dais. Over to you.
I request chairpersons to introduce the first speaker.
Good afternoon, everyone. It gives us an immense honor to us to introduce Dr. Anand Padmakumar. He is consultant in anesthesia and critical care, honorary lecturer, Sheffield University, UG lead for anesthesia and critical care, college tutor in anesthesia, and Chesterfield. He is associated with Chesterfield Royal Hospital NHS Foundation Trust in Chesterfield. He is going to speak next.
Good afternoon, everybody. Thank you so much for having me today. Special thanks to the organizers and my friends who are in the audience. It brings a great honor and pleasure to be here because I'm a product of Mysore Medical College, and it's almost surreal to be back here to talk to all of you and the esteemed audience. So thank you for the introduction, chairpersons. My talk today is on fulminant hepatic failure and the ICU management of it. And I appreciate there are a lot of anesthetists and postgraduate anesthetist students in here today, so I'll try and keep this as balanced as possible to give some pearls of wisdom, if I could, for the anesthetists there as well. I know not all of you will practice in intensive care, but you will be dealing with potentially some of these patients in the emergency department for the initial stabilization. So the aim of the talk today is to give you an overview of acute liver failure. I'm not going to delve much onto the pathophysiology side of things because the management is the main focus of the talk. I will try and touch base on some of the pathophysiological changes that happen during acute liver failure and how we can manage this in a critically ill patient in intensive care setting. And I'll try and give you some updates on the guidelines currently that are there for the management of the ALF patient. So ALF is a very rare condition, thankfully, and it is, when it happens, it has a high impact on patients. So this can lead to, in the severe cases, it can lead to a high mortality and morbidity of up to 75% of these patients may not survive it if we don't identify and treat this in an early stage. Patients with ALF should ideally be managed in an ICU setting, but some of these patients may present to you in a different condition, in a different setting, but they ultimately will be better managed in a specialized unit such as a liver transplantation center. So what is ALF, or acute liver failure? This has been termed differently in different textbooks and different literature. It is also known as acute hepatic failure, fulminant hepatic failure, but the current definition of acute liver failure is based on 4 components. The first one is there has to be a severe acute injury to the liver, and this can be of various etiologies, such as drugs, such as infections, etc., and we'll come to that in a moment. And there has to be a synthetic impairment of the function of liver. So this can be measured in the form of a raised INR or a raised prothrombin time. The other third component is an altered mental status, such as conscious level could be altered. They can be either confused, agitated, or they could be in deep coma. And the fourth or most important component is that for the definition of ALF, which should not be confused with the acute decompensation of liver disease, chronic liver disease, for the fulminant hepatic failure, this has to be in a patient who did not have any previous liver conditions such as cirrhosis or a long-standing liver disease. And how we define the acute nature of this condition is based on the development of encephalopathy from the onset of jaundice. The interval between jaundice to encephalopathy is used as a measure, and that is used further to subcategorize the ALF patients. So according to the Western studies, the definition of ALF would include any patient who developed jaundice about 26 weeks ago and then develops encephalopathy 26 weeks down the line. They could still be included in the ALF category of the definition. However, the patient population is different in India, and how they progress from jaundice to encephalopathy varies from the phenotype and the geographic region, but also they can have varied etiologies. In the West, you'll see in my next few slides, the etiology is vastly different, and it's mostly drug-related, overdoses or drug-induced liver injury. Whereas in the Indian population, it is vastly, the commonest cause is infection, and it's hepatitis E or B infections. And the progression of encephalopathy can change. So the definition by the Indian National Association for Studies of Liver clearly identifies the jaundice to encephalopathy duration as less than 4 weeks. So anybody with a jaundice to encephalopathy less than 4 weeks is the definition of ALF in India. So based on the duration of the illness from jaundice to encephalopathy, they can be further subcategorized into HALF, ALF, or SALF. The hyperacute liver failure, where the encephalopathy develops within a week of developing the jaundice, and the acute liver failure is between 1 to 4 weeks, and the subacute is between 4 weeks to up to 12 weeks. As you can see, the etiologies are vastly similar, but the key difference is that in the subacute category, you don't see pregnancy-related etiologies. The other thing you will notice is, as I mentioned earlier, there's a significant geographical divide between the etiologies of acute liver failure in the West and that in India and those in the Far East. It's a bit of a busy slide, but if you can focus on the Western population, which is vastly UK and US, more than half of them are drug-related liver injuries. And the pathophysiology of this and the outcomes and the prognosis for these patients is different in that they can be potentially treated, and some of them may not even need to have liver transplantation, etc. Whereas in India, as you can see, the vast majority of the ALF patient population will have infection as the primary etiological source. In other countries, it's a mixture of all of these. So a patient who presents to you with ALF will pose a number of management challenges, and we'll try and focus and unpick some of these as we go along. So ALF is a specific liver condition. It's almost, it is a syndrome of clinical features, and it's characterized by rapidly progressive nature, which often leads to not just damage to the liver, but a multi-system involvement such as multi-organ failure and organ impairment in organs other than the liver. Some of the prognostic models we have heard of or used in our clinical practice come from the Western countries, and these are in the form of King's College criteria, as you may have heard, Clichy criteria, and MELD scoring systems. Now, these are prognostic models that have been well established, especially in the West, and these scoring systems have a twofold advantage. One is that they identify the patients who require liver transplantation, but also they give an indication of the prognosis and the risk of mortality from the presentation. However, as I slightly alluded to earlier, the patient population is different in India in that the onset of jaundice and the onset of encephalopathy duration can be vastly different. And the etiology is usually due to infections in the Indian setting. And this can lead to perhaps an earlier onset of encephalopathy, and hence we have a more specific modeling for prognosis, and this is often used in the context of liver transplantation as well. And this is known as the ALFED model. This was developed by Kumar and their colleagues. So this has the four major components, the parameters that you see, the progression to hepatic encephalopathy, INR, and the ammonia concentration within the arterial circulation, and the serum bilirubin concentration. So the minimum score, obviously, you get is 0. The maximum you get is 6. The higher the score, the worse the outcomes and the mortalities. So the key difference between the Indian model and the Western models is that the Western models is a snapshot at the beginning of the presentation of the illness. So it's often known as a static modeling, where it's often based on, almost as an analogy in cricket, if there are followers here, it is an expert opinion, if you like, so, where the presentation is of a patient at the beginning of the illness is looked at. Whereas the Alfred scoring is more of a dynamic measurement tool, where the prediction of the outcome or the probability of an event happening is predicted on a dynamic basis. So as you can see, as the illness progresses, the ups and downs of winning or losing can change. And hence, the Alfred model is considered a better tool for, certainly for the Indian setting. Coming to the management of ALF patients, one of the guidelines that is globally accepted is the Society for Critical Care Medicine, and these is a combination of 29 experts who have been brought together to develop a consensus management guideline for the management of not just the acute liver failure, but also for the decompensated acute liver failure in the context of chronic liver disease as well. So I've tried to summarize some of these key management strategies and developed a little guide for us to sort of think about. Now, as anesthetist, we like to structure things. We like to organize our management into an algorithm or a plan. So I'll use the cliched version of A, B, C, D, E for the sake of convenience. I'll go over the pathophysiological changes that happen in ALF on the one hand, and I'll try and provide the management strategies to go with it. So, what changes do we anticipate in a patient with ALF in terms of the airway and breathing? Because of the low conscious state, they tend to have a compromised airway. This can be in the form of a risk of aspiration. This can be due to a hepatic encephalopathy, which can be of a higher grade to lead to coma. Or it could be due to an intracranial pathology such as a bleed. Often these patients have abnormal clotting. And this could be a drug-related problem as well. So all of these can lead to the same problem, which is a compromised airway, and there can also be a lung injury due to a systemic inflammatory response to the hepatocyte damage. So these patients will need early intervention in terms of the airway management. So early tracheal intubation is definitely indicated in patients with a higher grade of encephalopathy. This not just reduces the airway risks, but also protects the airway and helps us manage the intracranial pressure better with ventilatory strategies. The lung protective ventilation is applicable in patients who have developed ARDS, where we tend to use low tidal volumes and adjust the peak and expiratory pressure to regulate the intracranial pressure and balance it against the ventilatory requirements and the cerebral perfusion pressures. One of the bigger changes you'll come across in ALF patients is the cardiovascular changes. Because of the massive cytokine release due to hepatocyte damage, you will often see a reduction in the systemic and the splanchnic vascular resistance, and this will lead to a shocked situation with a high cardiac output condition. You will know from large studies that have compared the use of crystalloid and colloids, and I think there is a talk further down where you'll be spoken to about the use of fluids in critical care context. So I won't dwell into this much, other than to say that use crystalloids as your first line of approach. But certainly in the patients who have ALF, the SCCM guideline recommends the use of albumin because it is a very good volume expander, as you'll know. So although this has low evidence, it is common that we use albumin as a resuscitation fluid as well in patients who have a cardiovascular collapse. There's high evidence to avoid the use of starch or gelatin-based fluids such as gelafusin and heta starches. These can lead to increased mortality and renal injury. We also recommend the use of invasive monitoring of arterial pressure and aim for a mean arterial pressure of greater than 65, unless you are worried about a significant raised intracranial pressure where you might need to target a higher mean arterial pressure. Cardiac output monitoring device of any preference would be beneficial, such as echocardiogram, LIDCO, etc. And the vasopressor of choice is still noradrenaline. However, second-line drugs such as vasopressin can be added as well. Other more physiological changes that happen during ALF are of the CNS. So this is primarily due to the liver synthetic function is impaired, so there is accumulation of ammonia. This is water-soluble, crosses the blood-brain barrier, and increases causes neuronal damage and raises the intracranial pressure. It leads to high mortality in the untreated patients, and this used to be the biggest cause of mortality in ALF patients. But now, with better intensive care management and recognition of this problem early, we are able to reduce the mortality due to the raised ICP. So how can we manage the intracranial pressure? So this can be done by monitoring it closely through invasive devices such as the intracranial bolt, and we tend to reserve this now for more complex patients or those who are at a much higher risk of developing intracranial hypertension. So aim is to reduce the cerebral oxygen demand and reduce the intracranial pressure through either giving hypertonic saline or mannitol, and to consider renal replacement and maintaining normothermia wherever possible. The quadruple H therapy is recommended by the guidelines, which is hyperventilation, hemodiafiltration, hypernatremia, and hypothermia. So hyperventilation regulates the carbon dioxide concentration, and that has a beneficial effect on the intracranial pressure. Hemofiltration, where you can significantly reduce the ammonia concentration and reduce the damage to the CNS. Hypernatremia acts as a osmotic diuretic, increases the tonicity and helps with the fluid shifts. Hypothermia would reduce your ammonia production and also protects the CNS and the brain. So as I mentioned earlier, we'll need to consider early intubation, heading the patient, causing a head up, nursing the patient head up by 30 degrees is beneficial in reducing the cerebral edema. And measuring the SjVO2 can be helpful in guiding which way to manage the ICP. There can be significant derangement of your clotting, and this can be monitored mostly, but very rarely we need to intervene. We can use elastometric measures such as ROTEM or TEG, but also avoid the urge to correct the INR or PT just for the sake of doing it. If there is active bleeding, correct it. Otherwise, these are important markers for synthetic function of the liver. Invasive lines can be safely inserted with the use of ultrasound guidance, especially if the platelets are greater than 30 and the fibrinogen is greater than 1. Renal impairment is very common and it increases mortality again. However, early consideration for renal replacement therapy is important, and this will help in multiple levels to maintain temperature, reduce the ammonia levels, correct the metabolic acidosis, and you could use high-intensity ultrafiltration if the ammonia levels are significantly high. Try and avoid using citrate anticoagulation because it can accumulate. It is metabolized in the liver. Other systems can be involved, and this can be in the form of hypoglycemia or the metabolic functions, and there can be significant electrolyte abnormalities. So have early thoughts about what antibiotic you would want to use. Consider antifungal treatment because these patients are at specific risk of fungemias. And consider prophylactic antibiotic, especially in those who are listed for super-urgent liver transplants. Monitoring blood glucose, I don't need to emphasize the importance of this. This is a very important thing that can change the outcome of the patients. Establish early nutrition in these patients as well. I know I'm overrunning a little bit. Just the last couple of slides. Specific therapies have been considered, especially in the context of paracetamol overdose. N-acetylcysteine can reverse the damage to hepatocytes. Steroids can be used in autoimmune hepatitis and alcohol hepatitis as well. And if there is Wilson's disease in the picture, you could consider chelating agents. High-volume plasma exchange is a recognized therapy where, especially in the patients where liver transplant has liver transplantation has not been recommended. So these are patient populations where you are conservatively managing them. High volume plasma exchange can help improve the outcomes. So this is just a graph to show the survival of some of these patients who have undergone high volume plasma exchange, up to 4 times their plasma volume. And especially in children, especially in patients who have had pesticide poisoning, you can reverse the condition and you can prevent them from having liver transplants. Liver transplant remains the mainstay of treatment in those where conservative measures have failed. And we often use King's College or Alfred criteria, but they're committed to a lifelong immunosuppression. And this is not a simple decision. It needs to be a very considered and a multidisciplinary team decision. So in summary, we've looked at what acute liver failure is. It is a multi-system involvement, and it is very difficult and challenging patients to manage, especially in the ICU setting. But it's important to identify the pathology early so we can initiate the appropriate treatment early, and these can potentially prevent some of these patients not requiring transplants. And the post-transplant care and the commitment to in-hospital stay thereafter can be quite challenging as well. So it's just a brief overview. It's a big topic, but I'm happy to take any questions at the end. Thank you.